بسم الله الرحمن الرحيم. Histosalpingiography interpretation technique, anatomy and pathology. Histosalpingiography, the first reported using oil-soluble contrast by Carey in 1914. Then lipidol was gradually replaced by water-soluble contrast media. This is the oil contrast. It is more dense. You can see here the fallopian tubes. We will see the anatomy later on. This slide I used to put it, but nowadays we didn't use lipid soluble contrast here in Egypt especially. We didn't use lipid soluble contrast, it's not so much available. But in long ago, the gynecologists usually need lipidol. Because lipidol, they say that it has therapeutic effect rather than the water-soluble contrast. So how to differentiate between lipidol-soluble contrast and water-soluble contrast? Lipidol-soluble contrast shows a sharp image. However, the ERG and the ampullary ERG are clearly visualized more with the water-soluble contrast because it is not so dense. The lipid-soluble contrast causes minimal pain, while the water-soluble contrast gets absorbed within hours and do not leave any residue, and it is more painful. There is delayed absorption. Here the absorption is within hours. Risk of lipogranuloma formation in cases of tubal block or hydrosalpinx. In the water-soluble contrast, there is no granuloma formation, or it is rare. Intravasation of contrast with possible risk of oil embolism, and this was a problem. But here the intravasation is not so dramatic because usually just it is excreted in the kidney. But there is no risk of any oil embolism. In the lipid soluble contrast, we need delayed film after 24 hours. But here we do the control film after 15 to 20 minutes only. It is widely used and preferred, the water-soluble contrast, because, as I just said, the lipid-soluble contrast is not available. The pregnancy rate is doubled with the oil-soluble contrast. This is lipidol histosalpingiography. You see here, this is dense contrast, not as we acquainted with the water-soluble contrast. And here there is globules because it is oil. So the oil appear as globules in this is the spell of contrast, and the spell of contrast appear as a drops or globules like that, and this is characteristic to the oil soluble contrast. But as we see here, the mucosa is not so much delineated here. So here the mucosa is not so much delineated in the lipid soluble contrast. Then came the important question, when to schedule the examination. When to schedule the examination, some books or some articles say that in the first half of the menstrual cycle, best timing from 4 to 7 days. Some say in the 10-day rule, up to 10 days of the first part of the cycle. But to me, I say that this depends on the cycle of the female. If the female is 28-year cycle, and so the ovulation is about to occur at 14 days, so we must do it after the end of menses by 1 day. But the best timing after the end of the female menses by 1 day. Why? Because the blood, by that, the blood has cleared from the uterus. The isthmus is most distensible. The fallopian tubes are more readily filled, and the endometrium is not thick, because the thick endometrium will appear the double wall sign that's not it's pitfall in the imaging of the hysterosalpingography. Okay, طيب if the female has amenorrhea or irregular cycles, then we must do pregnancy test before the start of examination in all cases, because sometimes accidentally, although rare, you are confronted with a pregnant female and she has amenorrhea or has abnormal cycles. So if there is abnormal cycles, then before doing, we must do a pregnancy test. Hysterosalpingography is a fluoroscopic examination of the uterus and fallopian tubes. Indications in cases of infertility, main indication to assess the uterine morphology and tubal patency. This is the main indication nowadays. In recurrent and spontaneous abortion, I think we do ultrasound more to assess for the cervical incompetence. Ultrasound will be better. And in the post-tubal ligation, in order to assess that the tubes are ligated, or after tubal recanalization, if we do interventional recanalization or laparoscopic recanalization of the fallopian tube, we can do hysterosalpingography after to assess that the tubes are patent. Contraindications, of course, pregnancy, active pelvic infection, and this is important point. What is active pelvic infection? Active pelvic infection, that there is discharge, offensive discharge, copious discharge, but not the monilia that we found in most of cases. If we found just this yogurt-like monilia, but it's not so extensive, we can do the examination, but after proper cleaning of the cervix and the perineum. Vaginal bleeding, of course, and recent pelvic surgery. What are the complications? Sometimes there is common complications that occur, and you must say to the patient before the start of examination. Common but self-limiting, like abdominal cramping, vaginal spotting, that's okay, there is no problem for vaginal spotting, and she can pray no problem for this vaginal spotting. Vascular intravasation. They are common complications, but they are self-limiting. Also in the abdominal cramping, you say that the patient that you will feel pain like that of menses. So you must explain the procedure well to the female before the start. Rare but serious complications, pelvic infection. If you have, if you feel that there may be pelvic infection, the instruments are not so well cleaned, so you can give antibiotics. Contrast injection reaction, especially after intravasation, and this is very important entity. You must keep with you corticosteroids or Avil in order, if there is reaction, you can give this female these medications. What are the medications used in these cases? Antibiotics might be required 1 day before and few days after the examination if there is history of previous examination, if the patient has hydrosalpinx, and these hydrosalpinx may cause stagnation and added infection. When the maneuvers are fairly sanguineous, if there is bleeding when you grasp the cervix, there is some bleeding, or if the fallopian tube present certain degree of dilatation. The suggested antibiotic regimen is metronidazole at the time of the procedure, or doxycycline twice daily for 7 days in order to cover the spectrum of bacteria. Buscopan. Buscopan is very important. I used to give it 15 minutes before the start of examination in order to eliminate the element of tubal spasm. So this is very important. You must have steroids or prednisolone in case that reaction occurs. So better to give Buscopan before the start of examination. This is the equipments used. We have here a cascospecula. We have Valcellum multiple toothed volcellum, and we have sound. And this sound is very important. When you find resistance, sometimes there is tightness at the level of the internal os, so you have to introduce the sound in order to pass this tightness. And this is the cannulas used. I prefer this one, the corkscrew type, because this can fit well to the cervix and there will not be contrast eliminated outside the cervix. And here this is another one with this pulp in order to fit to the cervix. There is this narrow one and this one with rubber part. The problem that this thin one can cause extravasation from the cervix during the injection, so take care. Try to choose that one that fit to the appearance of the cervix you see. If it is pinpoint cervix, you can use this one, but if it is capacious cervix, better to use this, the large caliber of this corkscrew type. How to start the examination? The patient is placed on the fluoroscopic machine in gynecological position, lithotomy position. After cleaning the external genital area with antiseptic solution, the vagina is dilated by gynecological dilator. The cervix is localized and cleaned with iodine solution afterward, and the uterine cervix is straightened by one at 12 o'clock position or two at 9 and 3 o'clock. Usually we try to straighten the cervix. If you find the cervix is looking downwards because the uterus is retroverted or looking to one side, you try to grasp the cervix in order to make the cervical os in the center. But try to be away from 3 and 9 o'clock because this 3 and 9 o'clock is vascular due to the presence of arborization of the uterine artery at that part. Like this one here, we have, this is the cannula, and here the uterus is not in good position because we didn't grasp the cervix by the toothed volcellum. So here I couldn't see the right tube well. I couldn't see if there is filling defect or not because the uterus is upside down. But when I put a volcellum and I straighten the uterus, you can see here this is the uterus and this is both fallopian tubes appearing well. So better to use the volcellum in order to get better position of the uterus. The cervix is prepared with antiseptic and grasped with a toothed tenaculum. Gentle, slow placement of the tenaculum, grasping only enough tissue. Don't take only a small part of tissues. You must grasp a good amount of tissue in order that there is no slippage with hurting the cervix. Adequate stabilization of the cannula is recommended, or all air should be removed from the cannula by priming it in the vertical position. Holding the cannula first in the vertical position, try to eliminate all the air inside, and then apply the tenaculum with one hand to occlude, to try to occlude the cervix well with the cannula. A balloon catheter may be used, but this balloon catheter is expensive for us here in Egypt. The balloon catheter is expensive and it is used once, not like the other cannulas. A balloon catheter may be more suitable for patients with cervical stenosis, and some patients experience discomfort during the inflation of the balloon, and this catheter that we use in the technique of sonohysterography. This is the balloon inflated, but here I have a comment. When you inflate the balloon at the end of examination, please deflate the balloon in order to see the cervix. You here bypassed the cervix, so if there is something cervical, you have already bypassed. So you have to deflate the balloon and try to better to delineate the cervix. Some tips for a good successful technique. First, as I have just said, choose adequate catheter size. Inject contrast in the catheter prior to insertion to avoid injection of air bubbles. If the uterus is retroverted, place the speculum upside down. You can place the speculum upside down. If the cervix is tilted posteriorly, try to push the uterus down and ask the patient to cough or strain. And sometimes we have problem with the patients that has secondary infertility with previous cesarean section. Sometimes the uterus, due to the fibrosis, is high up. So we have to start to push the uterus by manual examination and ask the patient to cough or strain in order to reach the cervix. So if the cervix either tilted posteriorly or it is elevated upwards by the adhesion from previous cesarean section. For better delineation of the uterine cavity and the tubes, we can use oblique view or tilt the table or the X-ray tube in order to better to rule out the presence of focal masses or the abnormal position of the fallopian tube. Get adequate time for tubal filling and spill. If the tubes are not appearing in the first time, please give time and start to infuse very, very slowly in order that the tube can open. To aid tubal filling, we may aid patient to cough or do valsalva. This preliminary scout film is very, very important in order to rule out if there is any abnormal opaque shadow in the pelvis and in order to adjust the dose. Of course, when we do it under fluoroscopic control, we can, with DICOM viewer, we can just adjust we can adjust the dose, not the dose, we can adjust the brightness and contrast. But the main aim is to exclude the presence of opaque material. Like this one, I get it from the Facebook by this our colleague. This was hysterosalpingiography, but no preliminary film was taken, and there is some like a mist towel here, and there is irregularities present here all through. So please take a preliminary plain film. This is another case. In the preliminary film, we have a calcified oval shadow. It's likely a calcified myoma. And when we do the histro, if we do the histro before the preliminary film, we can not say, is this a lesion delineated by contrast or this is a calcified lesion. Of course, we have this uterus is irregular in shape with the stretching of the cervical canal. Mostly this is a fibroid uterus, and this is one of the fibroids that appear calcified. Again, very important to take preliminary plain film. Filming at least 4 serial films. We must take 4 serial films. See here, if I see first film, I could say that it may be normal, but it's not normal. There is progressive dilatation of this fallopian tube and loculation of the dye in the control film. So this is hydrosalpinx. So here there is hydrosalpinx of the left fallopian tube with loculated contrast in the control film. So serial films are very important. Then we came to the radiological anatomy. There's another case. This is the radiological anatomy. There is a slide before this one. Okay, this is just regarding the control film. We have here delineation of contrast in the, I will get the anatomy once more, but this is one of the pitfalls. This is the normal spilling of contrast in the peritoneal folds. This is not eloculation. This is just a contrast in one of the peritoneal folds. So this is not loculation. And here again, but this is loculation. This loculation, see here, the peritoneum is distracted upwards here, like that. So there is adhesions here. So this is peritoneal loculation. This is the normal appearance of the hysterosalpingogram. This is triangular shaped uterine cavity, and this is the normal fallopian tubes, we will say later. Sometimes we see normal non-pathological findings like air bubbles, and air bubbles you must take care, as we say before, that the cannula must be vertical and try to get all the air outside first. The air bubbles are rounded, often multiple, well-defined, mobile, so you have to change the position of the patient, usually displaced to the fallopian tube if additional contrast given. If you give additional contrast, the air bubbles will be displaced to the fallopian tube. But take care, sometimes when the air bubbles go to the fallopian tube, it causes heterogeneity, like the couple stone appearance of the mucosa of the fallopian tube, and this is not good. This is just air. Normal myometrial folds, when you found this longitudinal folds, and this occur more when the uterine cavity is not adequately filled. You will find here that there is longitudinal folds or yet parallel to the uterine cavity, and it occurs more if the endometrium is rather thick, if it is done in the late proliferative phase with thick endometrium. Prominent cervical glands, like here, this is air bubbles also. We have prominent cervical glands and the appearance of the previous cesarean section. This is air bubbles. Here, when injecting more contrast, they pass to the fallopian tubes. Okay. This is the typical air bubbles. Here also there is air bubbles here, and this the double wall fold of the endometrial cavity. But there is homogeneous smearing of the peritoneal folds. Here there is the intravasation. This is the myometrium here is delineated by vascular and lymphatic structures, and subsequent filling of the internal iliac veins, and the ovarian veins also here are filled. But the fallopian tubes here are seen, they are patent, but they are seen in the control film also. So this is an intravasation. Intravasation on hysterosalpingogram is characterized firstly by opacification of the myometrial vessels, usually veins, which appear as fine lace-like network or reticular pattern surrounding the uterine cavity, and then enters larger pelvic veins. Intravasation may indirectly indicate tubal occlusion due to the increased intrauterine pressure. But of course, in this case, there is no occlusion because both fallopian tubes appear normal. Intravasation is one of the pitfalls that may mimic intraperitoneal spillage in an occluded tube. Another differential diagnosis may be uterine perforation if you found, but it will not delineate the myometrium as we see in cases of intravasation. There is another case of intravasation, but here the fallopian tubes appear normal. So it is just done, maybe the technique done early, in early post-menstrual with the vessels still not closed, and so this is another cause of intravasation, but the tubes here appear normal. Intravasation, the tubes patent, exam done early, and this is the cesarean scar we will see later. Non-pathological findings in the cesarean scar. The most common appearance that we see in the last slide, this one, This is a wedge-shaped scar. Here, wedge-shaped small defect that we see on ultrasound. We say cesarean scar niche. Linear thin defect in the uterine body. Sometimes we can see there. Cesarean scar defect at the isthmus of a septated uterus. This is a septated uterus, and here there is a cesarean scar defect. Sometimes the cesarean scar is more than that. It causes outpouching at the cesarean scar. Here also there is the bulldog appearance. The cesarean scar is hanging down like that, like a bulldog appearance. This is unilateral and this is bilateral. This one of the appearance of these cesarean scar defects. Back to the radiological anatomy. Here we have the uterine cervix. The first part to be opacified is the uterine cervix. Uterine cervix is funnel-shaped with a smooth cervical contour or ball-shaped cervix. Sometimes we have prominent cervical glands. We say that they are aggregated feathery plicae palmata, spindle-shaped appearance of the cervix. But sometimes we have different appearance of the cervix. We can see here there is constriction at the internal os. This is the cervical palmata. And this is the spindle-shaped cervix. We can see also well-defined narrow isthmus, or we have constrictive band or dilated isthmus. This we can see in cases of cervical incompetence. A prominent cervical glands. Here there are prominent cervical glands. بيبقى في dilatation and elongation of the cervical canal with thickened prominent plica. This case with chronic cervicitis, it is more exaggerated. But when you find cervical glands like we see in the last examination like this is normal. But this is exaggerated in case of chronic cervicitis. We will stop here with the normal radiological anatomy. Regarding the radiological anatomy of the uterus here is normal in shape. I think here there is a slide here on the normal shape of the uterus. A normal intercornual distance تبقى 3.5 centimeter, and the fundus may be flat or mildly concave like that. This is the normal radiological appearance, and then in the next lecture we will start to talk about the detectable pathology. Thank you.